involved. At the same time, if they ask, the same question is asked, the most common structured or like which the chance of injury during IJV cannulation is, then what might be their answer? If it is same thing they ask for IJV, then it is carotid artery, which is very proximity, so there's high chances of puncture. So when you are not cautious. So if during subclavian vein cannulation, the pneumothorax, and in conditions of IJV, it is carotid artery. Done. So this question. Again, this is a typical example of a question where the answer might be very easy, but the question seems very complicated, or like which you will get panic. A resident at the emergency department is preparing for a lumbar puncture in a 26-year-old female with suspected subarachnoid bleeding. Although she presented with altered sensorium, CT brain was found to be normal. During lumbar puncture, which structure is pierced after the spinal needle crosses interspinal ligament? Ligament of flavum, arachnoid membrane, areolar tissue, subarachnoid space. In this question, even if they remove all this question, during lumbar puncture, which structure is pierced after spinal needle crosses interspinal ligament? Even with this, the answer remains the same. But this is how the questions are being asked. If the questions have become lengthier, please don't panic. There, the clue again lies in the 1 or 2 words. Try to pick up those points. Okay. When you see these sort of questions, laugh, relax for a while, and like be happy that you find out the clue as soon as possible and keep answering. So here, a resident, emergency medicine department, lumbar puncture, 26 years, subarachnoid bleeding, altered sensorium, CT brain, all these things are irrelevant. So it's all just to confuse or like waste your time. Here, during lumbar puncture, which structure is pierced after spinal needle crosses interspinal ligament? Simple form. What is the answer? Again, it is, whenever you are in doubt, write out here: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, arachnoid membrane. These are the structures which are pierced. Now here they ask which spinal after spinal needle crosses interspinous ligament. The next thing is ligamentum flavum. Simple, straightforward question, but don't get carried away with the length of the question. Okay, the answer is ligamentum flavum. Then, which of the following intervention can decrease pain and toxicity in local anesthesia? Again, easy question presenting in a different way. See the options: alkalized anesthesia, adding adrenaline, cooling local anesthetic, using thinner needle. Very good. See, by adding adrenaline, what happens? Adding adrenaline, it decreases the absorption and increases duration of action, but it doesn't have any effect with the pain. Cooling local anesthetic doesn't have any effect. Using thinner needle, by giving thinner needle, while piercing it decreases, but when you are giving it, the toxicity and all is not relevant. But by alkalizing the anesthetic, alkalizing means adding soda bicarbonate. By adding soda bicarbonate, what does it do? It alters PK by PA ratio. By doing so, it causes rapid onset, increased duration of action, less subcutaneous pain, improved quality of block. Also, it causes decreased toxicity due to slow absorption. So rapid onset, increased duration of action, less subcutaneous pain, improved quality of block, decreased toxicity due to slow absorption. So this is what you want to remember. Similarly, the same question asked in a different format. That's it. Like, don't worry about these things. Then, the person who demonstrated the effect of anesthesia successfully for the first time: Wells, Moton, Beer, Kolkola. Answer: very good. It is WTG Moton who successfully demonstrated anesthesia for the first time. It is WTG Moton on 16th October 1846. So that's why it's celebrated as World Anesthesia Day. He administered ether. Who is Horace Wells? Who is Horace Wells? Is the first public demonstration of nitrous oxide. Who is August Beer? August Beer is first to demonstrate IV regional anesthesia. Who is Carl Koller? First to demonstrate analgesic properties of cocaine. When you say Carl Koller, you have to remember about cocaine. Okay. Then coming to the next question. Which is false among the matched persons to the drug or instrument? Which is the wrong match? LMA, Orchibrain, endotracheal tube, McEwen, cocaine, Carl Koller, chloroform, Harold Griffith. Answer? Very good. So LMA was first introduced by Archie Brain. Endotracheal tube was invented by McEwen, and it is invented by McEwen and popularized by Ivan Magil. Cocaine was introduced by Carl Koller, and chloroform, it was introduced by James Young Simpson. And it is popularized by John Snow. John Snow is the one like who is also the father of epidemiology. If you remember the cholera outbreak in London and the Broadway Street, and you might have seen in the SPM Park textbook that picture that is related to John Snow again. Okay, and who is Harold Griffith? Harold Griffith is not related to chloroform. Harold Griffith is the one what we should first curare products like muscle relaxant. He's related to the muscle relaxants, so not related to the chloroform. Okay, these are then ESRD, very important. ESRD, end-stage renal disease patient with regular ongoing dialysis for lap cholecystectomy falls under which AAC physical status classification? This was a question, similar question was asked in the AIIMS. So again, potential question. End-stage renal disease with regular ongoing dialysis for lap cholecystectomy falls under which AAC physical status classification? 3, 4, 4E, 3E. Answer? Very good. It is 3. If you see this, it can't be 3 because lap cholecystectomy, laparoscopic cholecystectomy is not an emergency surgery, it's an elective procedure. So E is been ruled out. So again, I want you to remember the important points, the definitions at least first. 1, 2, 3, 4, 5, 6. What is 1? Is normal healthy person. 2 is mild systemic disease. 3 is not moderate. 3 is severe systemic disease. 4 is severe systemic disease with constant threat to life. 5 is moribund patient who is not expected to survive without operation. Who is not expected to survive without surgery. And 6 is a brain dead person. Brain dead. If you add suffix E indicates emergency. If you add suffix E indicates emergency. Okay. 1 is normal healthy person, 2 is mild systemic disease, 3 is severe systemic disease, 4 severe systemic disease with constant threat to life, 5 is a moribund patient who is not expected to survive without surgery, 6 is brain dead, E indicates emergency. A few extra points I want you to remember here. So remember, if it is pregnancy, it is 2, BMI 30 to 40 is 2, BMI more than 40 is 3. Then a patient with end-stage renal disease who is undergoing a regular dialysis is 3. Irregular dialysis is 4. Similarly, AKI or acute kidney injury it is 4. Then in addition to this, remember if it is history of CAD ischemic heart disease or CVA with less than 3 months history, more than 3 months history. If it is less than, it is 4, more than 3 months history, it is 3. Then remember the important thing, ruptured aortic aneurysm, polytrauma, ischemic bowel, all these things come under 5, even multi-organ dysfunction. In 4, sepsis and DIC comes under 4. Multi-organ dysfunction comes under 5. Then a brain dead person comes under 6. These are the things at least I want you to remember, very important. Okay. Pregnancy 2, BMI 30 to 40 is 2, BMI more than 40 is 3. Gestational disease, regular dialysis 3, irregular dialysis 4, AKI 4. History of CAD, ischemic heart disease, CVA with less than 3 months history is 4, more than 3 months history is 3, sepsis and DIC is 4, and ruptured aortic aneurysm, polytrauma, ischemic blood, MODS, there is multi-organ dysfunction stroke, they're all 5. Okay. Then next question. Modified Mallampati grading of the patient shown below. 1, 2, 3, and 4. See this image very carefully and tell me. Very good. It is C. You can easily, whenever you get modified Mallampati grading, see what are the, just see the uvula. What are the things which is seen in uvula? In uvula, if you see the entire uvula, if you see entire uvula, it is 1. Uvula without tip, it is 2. Only base of uvula is seen, it is 3. Uvula not seen, it is 4. Now see and tell me whether you see the entire uvula, or you see the entire uvula just without the tip, or you see only base of uvula, or you didn't see the uvula. Tell me, what do you see here? What do you see? Only base of uvula, so the answer is C. Very easy. Modified Mallampati grading, if you get a image-based question, please don't miss this. Very easy thing. And predominantly, you may get a question either from Mallampati grading 2 or Mallampati grading 3. Okay. So entire uvula is seen in 1, uvula without tip in 2, only base of uvula in 3, and uvula in 4. And modified Mallampati grading 1 and 2 are easy intubations. 3 and 4 are difficult intubations. Okay, this is what in 1 you can see complete entire palate, fauces, entire soft palate, uvula, hard palate, and all. So that is what you easily identify based on what all structures you see with the uvula, entire uvula, only base of uvula. And based on those, you can easily answer these questions. Then, next question. All of the following are difficult airway except CLG, Carmack-Lahane grade 3, modified Mallampati grading 4, Wilson score 6, thyromental distance 7.5 centimeters. Even if you don't know anything, like by going through one thing which you are very confident about, you can answer this question. Very good. Even if you don't know about Carmack-Lahane or Wilson, you can still answer. That is thyromental distance. That is how you have to approach the questions. When you are eliminating, when you are very sure about the answer, don't think much. So if it is suppose a very straightforward question, when you know one option which you are damn sure and one option which you are not sure and 2 options which you have never seen of, don't worry. If you are confident about the answer, go and mark it. Okay? Go, I mean, stick with your instinct and the gut feeling. Majority of the times you will succeed this. So when it comes to Carmack-Lahane grading, you know Carmack-Lahane grading 1 and 2A are easy intubation, 2B, 3 and 4 are a difficult intubation. Then modified Mallampati grading, just now we discussed, 1 and 2 are easy, 3 and 4 are difficult. Then Wilson score, anything more than 3 is a difficult intubation. Then you know thyromental distance less than 6.5 centimeters, thyromental distance, and sternomental distance less than 12.5 centimeters are difficult. So here they mentioned very clearly it is 7.5 centimeters, that is more than 6.5 centimeters. So it is not a difficult intubation, it is an easy intubation. Then All of the following drugs are to be continued on the day of surgery except thyroxine, atorvastatin, levipril, climpride. All of the following has to be continued on the day of surgery except thyroxine, atorvastatin, levipril, climpride. What is thyroxine? It's a thyroid drug. What is atorvastatin? It's a statin group of drugs. Levipril, anticonvulsants. Climpride is a oral hypoglycemic agent. Now tell me, what are the drugs that can be, first we'll come back here. What are the drugs that can be continued? Among CNS, what are the drugs that can continue? Among CNS, what are the drugs that can be continued? Anticonvulsants, antidepressants, levodopa, that is antiparkinson's drugs can be continued. Anxiolytic drugs, anxiolytics, antidepressants, anticonvulsants, levodopa. Then coming to CVS, statins, digoxins, beta blockers, anti-anginals, they can be continued. When coming to the respiratory, anti-tubercular drugs, asthma drugs can continue. Miscellaneous, steroids, thyroid drugs, progesterone only pills can be continued, eye drops, all these things can be continued. So if you see this, levipril comes under anticonvulsant, so it can be continued. Statins can be continued, and thyroid drugs can be continued. And what about glimepiride? Glimepiride is oral hypoglycemic agent that has to be stopped except metformin. So here, remember, what are the drugs that has to be stopped? Quickly to analyze. When it comes to anti-hypertensive drugs, all antihypertensive drugs has to be stopped. All antihypertensive drugs. What do we have to do? Whether we have to continue or stop. All antihypertensive drugs except ACE inhibitors and ARBs. ACE inhibitors and ARBs. All antihypertensive drugs can be continued except ACE inhibitors and ARBs. They have to be stopped. They have to be stopped. Okay, because they may cause profound hypotension. Then it comes to anti-glycemic agents. Anti-glycemic agents. According to the recent guidelines, metformin around 500 mg can be continued. Restall, metformin with more dose, more than 500 mg, and also other oral hypoglycemic agents has to be stopped. Other OHAs has to be stopped the day before surgery. Then you coming to insulin, short-acting insulin, long-acting insulin. If it is short-acting insulin, stop. Long-acting insulin in type 2 diabetes mellitus and type 1 diabetes mellitus. In type 2 diabetes mellitus, you can give half the dose, and type 1, sorry, 1/3 dose in type 2, and in type 1 you can give half the dose. Then we already discussed regarding aspirin less than 75 mg you can continue, more than 75 mg stop 3 days before surgery. Clopidogrel 7 days before surgery. Then heparin, again 3 things. It is unfractionated heparin or low molecular weight heparin you are using for prophylaxis, or low molecular weight heparin you are using therapeutic. Unfractionated heparin 6 hours, not days. Low molecular weight heparin prophylactic 12 hours, therapeutic 24 hours. Then warfarin use 3 to 5 days. You have to stop. So at least these are the things I want you to remember for sure. Okay, then coming to the next. So in this question, the answer is glyceride being oral hypoglycemic agents that has to be stopped. Then a 4-month-old kid posted for elective urological procedure has to be kept fasting from breast milk for how many hours? 2 hours, 4 hours, 6 hours, 8 hours. Come on guys, everyone. 4-month-old kid posted for elective urological procedure has to be kept fasting from breast milk for how many hours? Very good, it is 4 hours. So regarding the fasting guidelines in adults, 2 hours for clear fluids, 4 hours for semi-solids, 6 hours for solids, which is light meal, 8 hours for solids with fatty meal. At the same time, in kids, earlier guidelines say 2 hours for clear fluids, but a recent one, if you have the option, then it is 1 hour for clear fluids. If you have option of both 1 and 2, go for 1 because it's according to the recent guidelines. Then 4 hours for breast milk and semi-solids, 6 hours for formula milk, 8 hours for solids. So rather than asking straight how many hours breast milk has to stop, they'll create a scenario. So if tomorrow they ask a question saying that a 9-month-old kid is posted for surgery and at 11 a.m. and from what time the patient has to be kept fasting from breast milk? The option says 5 a.m., 6 a.m., 7 a.m., 8 a.m. What will be your answer? Surgery is at 11 a.m. From what time you keep? Yes, it is 4 hours. That is from 7 a.m. Don't get confused with this. Like if there's a clinical acumen like mathematics, like it's very easy and simply you can do that. Then, what are the gases present in liquid form? Gases present in liquid form are all except nitrous oxide, carbon dioxide, NOx, and cyclopropane. What is the answer? Fantastic, NOx. So gases which are stored in liquid form are nitrous oxide, carbon dioxide, and cyclopropane. The ones which are stored in gaseous form are oxygen, air, and NOx mainly. And nitrous oxide, see, air index is 1.5, oxygen is 2.5, nitrous oxide is 3.5, carbon dioxide 1.6, cyclopropane 3.6, and NOx 7. The colors of the cylinders very, very important. I repeat, oxygen is black cylinder with white shoulder, air is gray with white shoulder, NOx is blue with white shoulder, nitrous oxide is blue in color, carbon dioxide is gray in color, cyclopropane is orange in color. Please don't forget this. Very, very, very important. Okay, then contraindication for the procedure shown here: fracture cervical spine, fracture mandible, CSF rhinorrhea, short neck. While attempting this question, first of all, you have to know what are the things they have been asking here. What is the procedure being done here? First of all, what is the procedure being done here? What is the procedure being done here? Come on, guys. Type in the chat box. What is the procedure being done here? Very good. It's a nasal intubation being. You can see the endotracheal tube going through the nose. Nasal intubation. When you're putting a nasal intubation, what are the contraindications? What are the indications and contraindications? If you see, when there's a fractured cervical spine, is it indication or contraindication? It is an indication because you don't need during the nasal intubation, you don't need the flexion at cervical spine and the extension at atlanto-occipital joint, which is also called as sniffing or Nagel's position. You don't need that, so you can use in nasal intubation. You can comfortably use in fractured cervical spine. Fractured mandible, even in fractured mandible, you can comfortably use the nasal intubation because in oral intubation, you because of the pain and like movement, because you have to operate and all, like you can't do that. Then CSF rhinorrhea. When there is a CSF rhinorrhea, there's a leak here. When there is CSF rhinorrhea, and when you try to insert, like there's a high chance of infection, so you can't do that. Then in short neck conditions, again, where you can do manipulation easily, so you can use this for short neck nasal intubation, and with the fiber optic you can use. So this is an indication, this is an indication, and this is an indication, and CSF rhinorrhea is a contraindication. So what are the other indications for nasal intubation? What are the other indications? What are the indications of nasal intubation? As I said, fracture cervical spine, decreased mouth opening. Where are conditions where there is a decreased mouth opening? Like as we discussed already, fracture mandible, trismus, TMJ ankylosis. Okay. This is what very important we have to remember. And in conditions of difficult airway for fiber optic intubation. Fiber optic intubation. What are the contraindications? As I said, CSF rhinorrhea, because when there's a leak, coagulopathy, because when there's coagulopathy or bleeding disorders, you can't use, because nose is very highly vascular structure, where in the littles area is one of the most common, most vascular site, and even there's a small bleed, it obstructs the view. And in conditions of adenoid hypertrophy, it's all contraindicated. This is all about the nasal intubation. So in this condition, the answer here is contraindication. It is CSF rhinorrhea. Then coming to this, very important. The capnograph showed is suggestive of air embolism, curare cleft, bronchospasm, hyperventilation. Capnograph showed is suggestive of air embolism, curare cleft, bronchospasm, hyperventilation. Before coming to the answer here, I want you to remember the capnograph. They should be on your tips. So this is the normal capnogram. This is the normal capnogram. What you see this? These capnographs should be in your tips. This capnogram is normal in controlled ventilation. If you see inverted U shape, this is also a normal capnogram which you see in spontaneous ventilation. Then when you see slow increase is seen in hypoventilation. Sorry. When you see rapid increase like this, it is seen in malignant hyperthermia. See slow decrease seen in hyperventilation. So this is a rapid decrease seen in embolism. Seen in embolism, let it be pulmonary or airway, whatever it is, pulmonary embolism. So this is 6 capnography waveforms I want you to remember. Give me a second. Okay, then another set. If you see a capnography waveform like this, so this is characteristic shark fin appearance. Shark fin appearance seen in conditions of bronchospasm or airway obstruction. Bronchospasm or airway obstruction seen in asthma, COPD, etc. This one. Next. If you see this cleft, this is called as, what is this? Very good. This is curare cleft. This curare cleft that indicates spontaneous breath in a controlled ventilation. Spontaneous breath in controlled ventilation. If you see this in middle of the surgery, you administer muscle relaxant. Administer muscle relaxant. If you see the same in the end of the surgery, you administer reversal agent. Very important. Okay. Middle of the surgery, you administer muscle relaxant. End of the surgery is a reversal agent. Then, next. This is a flatline capnogram. This is a flatline capnogram where it becomes 0. Is seen in cardiac arrest, accidental extubation, circuit disconnection, and in esophageal intubation. Esophageal intubation is important. Okay. Then, if you see capnography waveform like this, less than 10, and suddenly you see like this, this indicates this is an ongoing CPR, and here there is a return of spontaneous circulation, ROSC, a return of spontaneous circulation. Okay, this is what you have to remember. This is the waveforms. And another, so it is basically, these are called as cardiogenic oscillations. Cardiogenic oscillations usually seen in children and those with thin chest wall. So these are the things I want you to remember. So these are the 10 to 11 waveforms. So normal control, normal spontaneous, slow increase hypoventilation, slow decrease hyperventilation, rapid increase malignant hyperthermia, rapid decrease in all embolisms. Shark fin appearance, you see the this is the shark fin appearance. Bronchospasm, airway obstruction, asthma, COPD, curare cleft, which indicates spontaneous breath and controlled ventilation. In the middle of the surgery, administered muscle relaxant. End of the surgery, a reversal agent. Flatline capnograph indicates cardiac arrest, accidental extubation, circuit disconnection, and esophageal intubation. And this is ongoing CPR and return of spontaneous circulation. And cardiogenic oscillations, you see children, and those in children with thin chest wall. No answer to this question. Capnograph showed is suggestive of? What is the answer? What is the cap? Very good. P, correct. Air embolism, you see rapid decrease. Bronchospasm, you see sharp fin appearance. Hyperventilation, you see slow decrease. Okay. Then, coming to the next question. Most accurate site for neuromuscular monitoring is? ADrPLEXUS, tibialis posterior, diaphragm, orbicularis oculi. Very good. It is orbicularis oculi. The most common site is ADrPLEXUS, supplied by ulnar nerve, but the most accurate is orbicularis oculi, supplied by facial nerve. Supplied by facial nerve. Then next coming question. Intravenous anesthetic agent which cause minimal cardiovascular and respiratory depression is propofol, thiopentone, etomidate, ketamine. Answer. Minimal cardiovascular and respiratory depression. They are asking, what are they trying to ask? It is basically most cardio stable they are asking. Most cardio stable. Very good. The answer is etomidate. Etomidate, see, if you see propofol, what does propofol cause? Propofol cause hypotension plus bradycardia. Thiopentone cause hypotension plus compensatory tachycardia. Ketamine cause hypertension and tachycardia because of sympathetic stimulation. So etomidate is one which doesn't cause neither hypertension or tachy or brady. So it's minimal cardiovascular and respiratory depression. It's most cardio stable. That is why etomidate is the agent of choice for cardiac surgeries like CABG and also for coronary angiograms and all. Okay. Then next question. What is the drug excreted by Hoffman's elimination? Galamine, atracurium, procaine, thiopentone. Again, it's very easy, like procaine and thiopentone is IV anesthetic, no relation. Procaine is a local anesthetic, no relation. And in this, among galamine and atracurium, it is very good. Easiest question, atracurium. See, atracurium and cisatracurium both undergoes Hoffman's elimination. What is Hoffman's elimination? Hoffman's elimination is nothing but spontaneous non-enzymatic degradation. And this is a question in PGI. What are all the pathways atracurium get metabolized? Not only Hoffman's, there's another called slow ester hydrolysis. Because of these two pathways, it doesn't need any metabolism or elimination in the liver or kidney. So that is why it is safe to use in renal failure, liver failure, pediatrics, and geriatrics. You have to be very careful and you should not miss any question related to this. Next, what are the constituents of the following? What is this basically? What is EMLA? What are the constituents of the following EMLA? What are the constituents? EMLA is nothing but eutectic mixture of local anesthesia. Yeah, tell me, it is basically, don't get carried away with the procaine. It is a combination of prilocaine and lignocaine, 2.5% each, 2.5% lignocaine and 2.5% prilocaine. Use it for IV cannulation, before IV cannulations in children to antagonize the needle phobia. Nowadays, these are also being used for ear punctures. Okay. So this is about EMLA, eutectic mixture. Only thing is, the only disadvantage is it has to be used, applied 30 minutes at least, slow onset, can't be used in emergencies, and it is contraindicated in broken skin because prilocaine is then, because of this prilocaine, it may cause methemoglobinemia. So we have to be very careful. Then next, methemoglobinemia is an adverse effect of prilocaine, halothane, fentanyl, haloperidol. Very easy question. What is the answer? Very good. Prilocaine. Prilocaine is the one which causes maximum methemoglobinemia because of its metabolite or orthotoluidine. which converts hemoglobin to methemoglobin. So the treatment is you give IV methylene blue, which converts methemoglobin back to IV methylene blue converts methemoglobin back to hemoglobin. Okay. Methemoglobin is adverse effect of blocking. Then in high spinal anesthesia, what is seen? Hypotension and bradycardia, hypotension and tachycardia, hypertension and bradycardia, hypertension and tachycardia. Very good. In high spinal anesthesia and in total spinal anesthesia, you see hypotension, bradycardia, and respiratory depression. So how do you treat? Simple. First of all, manage the airway. Airway management by taking care of respiratory depression by intubation and mechanical ventilation, and for this you give inotropes and vasopressors. So high spinal is where the effect is blocked till C3, that is diaphragmatic palsy, and in total spinal even respiratory center is blocked. Very important. Okay. And then as I repeat, most common intraoperative complication is hypotension in spinal anesthesia. Most common intraoperative complication in spinal anesthesia is hypotension. Most common postoperative complication is urinary retention. Okay. Then epidural anesthesia is given by which needle? Epidural anesthesia is given by which needle? Very good. Here, Sprotty, Whittaker, Quincke, these are all spinal needles, and epidural is given by Tuhai, 18 gauge needle. The spinal needles among this, Sprotty and Whittaker are pencil tip needles. Pencil tip needles, safe to use. Safe in the sense like they cause decreased incidence of PDPH. And Quincke needle, cutting type of needle, increased PDPH instance. Then when it comes to Tuhai needle, 18 gauge, it is used for epidural. And most importantly, how do you identify that you are in the right space? It is due to loss of resistance technique. Loss of resistance technique. There's another technique called hanging drop technique also, but most important is hanging drop technique. And spinal, you come to know by free flow of CSF. Here you use 18 gauge. In spinal, you use 26 to 27 gauge. Very important. And in epidural, the drug is deposited above the dura, that is between ligamentum flavum and dura mater. Okay, then coming to the next question. The drug which is not included in AHS CPR guidelines 2020, atropine, adrenaline, amiodarone, and naloxone. Come on, guys, answer. Atropine, adrenaline, amiodarone, naloxone. Very good. Atropine. If you see this, atropine has been removed from the routine AHS CPR guidelines in 2010, and vasopressin is removed in 2015. Naloxone is used in BLS, basic life support, in conditions of respiratory depression. And in ACLS protocol, you use adrenaline, amiodarone, or lignocaine. Adrenaline you use in both shockable rhythms and non-shockable rhythms, and dose is 1 mg every 4 minutes. And this amiodarone and lignocaine you use only in conditions of shockable rhythms. Only in conditions of shockable rhythms. Amiodarone, the dose is 300 mg bolus, followed by 150 mg subsequent doses. Lignocaine 1 to 1.5 mg bolus, 1 to 1.5 milligrams per kg bolus, followed by 0.5 to 0.75 milligrams per kg subsequent doses. Okay, this. Then coming to the next question. The compression ventilation ratio in infants without any advanced airway and in the presence of two rescuers, 30:1, 30:2, 15:1, 15:2. So don't get confused. Just when you see this sort of questions, take a pause and answer. When in infants, in the presence of two rescuers, it is always 15:2. So in adults, so the compression ventilation ratio in adult, basically in infants, in the presence of one rescuer, it is 30:2. In the presence of 2 rescuers, it is 15:2. The same thing in conditions of adults. In the presence of 1 rescuer, 30:2. In the presence of 2 rescuers, also it is 30:2. Then another important point, as I said, the major important changes of 2020 guidelines. Recovery component has been given importance, where like post-op CT, MRI to be done, all these things are discussed. Then post-op rehabilitation, post-recovery rehabilitation, post-cardiac arrest care has been prioritized. Then perimortem cesarean section, they made it. Perimortem cesarean section, increase the time from 4 to 5 minutes. If all arrest occurs. And what else they discussed in 2020 guidelines, most important, you can take use of your mobile devices to guide you during basic life support and ACLS. And one more important change in 2020 is the respiratory rate in infants and children, where it is 20 to 30 breaths per minute. These are the changes which occurred in this 2020 guidelines came on 2020 October 21st, and in 20 days, 18 days down the line, in the examination, there is a question based on this respiratory rate. So very, very, very important. The next question, the compressions during CPR in adults has to be given at which place? Lower half of sternum, upper half of sternum, middle of sternum, whole sternum. So ideally, see, that is what the intentionally this question was kept. Like, it is not, ideally, it has to be given on the lower 1/3 of sternum. But if it is not there, then go for the, which is the nearest, that is lower half of sternum. And in adult, if it is in infants, it is in the center of the chest. In infants, you have to give in the center of the chest. Then identify this vaporizer: desflurane, sevoflurane, isoflurane, halothane. Very good, desflurane. So desflurane is a Tech 6 vaporizer, which is a special vaporizer. It's blue in color. The colors, remember, halothane, isoflurane, sevoflurane, desflurane. Halothane is red, isoflurane is purple, sevoflurane is yellow, desflurane is blue. This desflurane is a special vaporizer. It is not a variable bypass vaporizer. It's a special vaporizer because it's electrical and because it has low boiling point and high vapor pressure. Low boiling point and it has high vapor pressure. And when we are discussing these compressions and all, like when BLS, again, remember one important thing: shockable rhythms and non-shockable rhythms. Rhythms which are shockable and non-shockable. The shockable rhythms are ventricular fibrillation and pulseless VT. Non-shockable rhythms are asystole and pulseless electrical activity. Here you use, if it is biphasic, use 120 to 200 joules, monophasic 360 joules. Very important. Then what is this? Very important. Identify the structure. What is this? Thiopentryl sodium, etomidate, sugammadex, hexanol. In this entire anesthesia, my class, I usually always say, like, remember this one structure. This is, so if you see even like this, 8 gamma cyclodextrin like this, not COVID virus, we see this. This is sugammadex, and remember, sugammadex has highest affinity. Sugammadex is a selective relaxant binding agent, and it has highest affinity for highest affinity for rocuronium. So it selectively binds the muscle relaxant and brings it. So this was the question. Sugammadex has highest affinity for which agent? The rocuronium. This one point, this question was asked thrice between 2020 and 2021 in INI-CET, NEET, and UPSC examinations combinedly. Just one point. Sugammadex has highest affinity for rocuronium, followed by vecuronium, followed by pancuronium. Very, very, very important. Sugammadex is very, very important, and I don't want you to miss this point. Sugammadex has high is the one selective relaxant binding agent, and it has highest binding property for the rocuronium, followed by vecuronium and pancuronium. Okay, then following scenario occurs in is a train of four where you see the constant but diminished response, which you see phase 1 depolarizing blockade, phase 1 non-depolarizing blockade, phase 2 depolarizing blockade, phase 2 non-depolarizing blockade. Very good. Phase 1 depolarizing blockade. As I keep saying, two things. Phase 1 block, you see constant but diminished response, which you see in succinylcholine in normal doses. Phase 2 block is seen in succinylcholine in high doses and in conditions of all non-depolarizing muscle relaxants. Here you see a fade phenomena. So phase 1 depolarizing blockade where you see constant diminished response. Phase 1 is not caused by non-depolarizing. Phase 2 depolarizing and phase 2 non-depolarizing both, it causes a fade phenomena like this. Okay. Then one last thing, I'll ask the question. I'll write down the question. Intentionally I kept it. What is the color of 20 gauge IV cannula? Gray, green, pink, blue. Come on, guys. What is the answer? If you see the recent INI-CET papers, this is, if you say like the easiest thing which in the entire INI-CET papers which has been asked is this one. If you see from 2020, once the INI-CET started, in these 5 examinations, they have asked thrice regarding this. Once regarding 18 gauge cannula, twice regarding the 20 gauge cannula. And the last time they had asked about the flow rates also. It's not just about the colors. I want you to remember the flow rates also. So please write down. Please write down the colors of cannulas. It is basically 14 gauge, 14, 16, 18, 20, 22, 24, 26 colors. 14 is orange, 16 is gray, 18 is green, 20 is pink, 22 is blue, 24 is yellow, 26 is violet or purple. The maximum flow rate, this is cannula size, color, and flow rate. What is the maximum flow rate? Flow rate maximum in ml. You can use up to 270 ml, 180, 90, 60, 45, 24, 12. This is roughly, if you can remember this, like in the examination, if they say in the 18 gauge, the option given was 93. So don't go and say that like 90, say 90 and 93 was given, so we don't answer that. So anything related to that, which is close to that, please go and answer. So 270, 180, 90, 60, 45, 24, 12 is what is the maximum flow rates. Okay. It is all about the IV cannulas. Then that's all about anesthesia T&D, and in our next 6 a.m. session and 9 p.m. sessions, we'll be having image-based questions discussion exclusively and quick important points which are relevant to the examination. That is what we will be discussing. And as I keep saying, guys, you are all champions, and coming out and stepping out of the comfort zone and attending this session, that itself immediately within less than close to like 16 hours of your NEET results is something like which has to be appreciated. And coming out of the comfort zone helps a lot, and all the miracles happen out of the comfort zone only. I have seen people like who are with the ranks of 20,000, 30,000 in NEET, like coming up and getting a double-digit rank in the INI-CET. It is very much possible. See, NEET was one examination like where it didn't go properly. It can't go like probably on that particular day you might have missed marking 3 questions, or you might have fumbled. And the same paper for the same person, if you have attempted the NEET on some other day or in the same day afternoon, probably your scores might have been different. That's exactly the point. Is like even when I give the same this anesthesia paper what you have taken in the morning, if I given in the afternoon, in the morning you may get like 60 out of 75, afternoon you may get 62, or it might be 58 or even 75. It all depends not on like one factor, so multiple factors. So don't even think about what happened. And now for the rest 56 days what you can do is what I want you to focus on. And as I keep saying, like I'll show you with examples, like the people coming up with 4-digit and 5-digit ranks in the NEET, ending up with the double-digit ranks and triple-digit ranks in the INI-CET, and it's all. And I said, only 1,000 people out of the 2 lakh people who got the results yesterday, only 1,000 people might have been back to the studies, and you people are among them, and that itself shows that how committed you are. And this coming out of comfort zone is definitely going to help, and all the very best. And we are here to handhold you for the next 57 days or 56 days to have a phenomenal INI-CET examination. And all the very best, guys. Like see you in the next further 6 a.m. or 9 p.m. sessions, and you keep seeing me like very frequently, and we all we all will together win. And just keep motivated, be positive, and we are going to do it. Once again, all the very best, and looking forward. From ADR, like we are there to help you out, guys. Like for the next this INI-CET program, this 56 days, we are going to handhold you, and whatever is needed in the form of 6 a.m. sessions, 9 p.m. sessions, leaderboards, and quick hackathon sessions. All these things we are going to take care of that, and important topics list where you have to focus, previous year questions. All these things we are going to help you, guys. Okay, fine. All the very best. See you in the next sessions.